So this is about acute pancreatitis. So acute pancreatitis basically means inflammation of the pancreas. So in this video I'm going to cover the causes, the pathology, investigations, and the presentation, of course, and the management, and also the complications. So the causes, the very popular mnemonic, I get smashed. So the causes include gallstones, ethanol, and ERCP are the most common causes, and the other causes include idiopathic. So in about 10 to 20% of patients, there's no particular cause for the acute pancreatitis. Trauma can cause it. Steroids, mumps and rubella, autoimmune disease like SLE, scorpion stings, of course, hypercalcemia, ERCP, drugs, and these drugs include azathioprine, NSAIDs, and diuretics. So those are the causes of acute pancreatitis. So now covering the pathology and presentation. So the pathology is pretty simple. So it's inflammation of the pancreas due to activation of the pancreatic enzymes causing the autodigestion and the inflammation. So basically what happens in certain causes, so for example, if the gallstone blocks the sphincter of Oddi, it can cause the fluid to back up and it increases the pressure in the pancreas, and this increased pressure causes fusion of the the lysosomes and the zymogens, and this fusion causes the activation of the digestive enzymes, and these enzymes like tryptase and chymase and lipase, all of these can then further cause damage to the pancreas, leading to inflammation. So that's the pathology in a nutshell. So presentations are pretty simple. So there's three main symptoms. The first main symptom that they present with is the epigastric pain radiating through to the back. Second is nausea and vomiting. And third is that they will be systemically unwell. So they will have a low grade fever. So what are the main investigations? So the main investigation is the amylase and the lipase. So these are the lab tests that you would do. So amylase first, because it's more commonly used. So if the amylase is raised greater than 3 times the upper limit, then that is diagnostic of acute pancreatitis. But lipase can also be used because it's more sensitive and more specific, and it's raised for a longer period. So if the patient has been having this long-standing epigastric pain, then you would prefer to use the lipase instead of the amylase. But amylase is more widely used, so amylase is first line. So in terms of the imaging, you can do an ultrasound, and the ultrasound is important to do, and its aim is to pretty much identify gallstones as the cause, and the diagnostic and CT abdomen is mainly to assess the severity, to look for any complications like the pancreatic pseudocyst or the necrosis, which I will go on to later, but it's essentially to assess the severity. So those are the investigations you can do, and another investigation which is optional is the ALT, and an ALT would be significantly raised in gallstone disease, so that's important to consider as well. So what do you do for the management of acute pancreatitis? So first you have to identify and treat the underlying cause, of course. So, for example, ERCP to treat gallstones in the common bile duct causing the acute pancreatitis. And once you've identified and treated and managed the cause, then supportive management is really important, because patients presenting with acute pancreatitis can be systemically unwell. So you would have to give IV fluids due to third space fluid loss, and an NG tube will only be used if the patient is constantly vomiting and they're unable to tolerate any oral intake or oral food. So 3, catheterization is important for fluid balance, because obviously due to the dehydration there's a risk of acute kidney injury, so you need to make sure you are balancing their inputs and outputs. And opiate analgesia, of course, because the patient will be in significant pain, so you need to make sure to give analgesia. And so that's the main management, and you would not give antibiotics unless you have suspected infection, unless there's CRP, ESR, indications of infection are rising. Then you will give antibiotics, otherwise you would not. So the complications we need to know is the local and systemic. So the local complications include pancreatic necrosis, pancreatic pseudocyst. So pancreatic necrosis is where the pancreatic enzymes cause the autodigestion, and the pancreatic pseudocyst is due to the collection of fluid containing pus enzymes in blood. And systemic is 1 DIC, 2 ARDS, 3 is hypocalcemia. So you get hypocalcemia because obviously the lipases that are being released, they're activated, and they start obviously breaking down the fat and causing release of fatty acids, and these fatty acids can then react with the calcium that's available to sort of form sort of chalky deposits and sort of take up that calcium, leading to the hypocalcemia. And then hyperglycemia, of course, because the pancreas is being destroyed, and obviously the islets of Langerhans are being destroyed with it. So there's going to be a decrease in the insulin produced, meaning there's going to be more glucose in the blood. So that is a summary of the acute pancreatitis.